Good morning.
Good morning.
As Dr. Poor mentioned, this is a process that we in the community have undergone over a number of years now, and happy to say that it is part of an increasingly growing collaborative of organizations. So it involves not only the Douglas County Health Department, but also neighboring health departments, as well as all of the health systems, and increasingly other community organizations, as you can see here as well. So as we look to the data that I want to share with today, a little bit quickly about how we went about doing this assessment. Probably the cornerstone was a population-based household survey that was administered at random throughout the three-county area of Douglas, or four-county, Douglas, Sarpy, Cass, and Pottawatomie counties. As Dr. Poor mentioned, in Douglas County specifically, we did a great deal of oversampling, so we have zip code level information for most of our indicators. In general, for today's presentation and some of our broader presentations, we're looking at Douglas County in 5 sections, essentially the city of Omaha, northeast, southeast, northwest, southwest, and then the western Douglas County zips. We did a very large number of surveys, very respectable error rates, so very robust data coming out of this survey. We also looked at secondary data, public health data from the CDC, the state health statistics, and also incorporated some input from providers in the community, both health providers as well as social service representatives, first responders, other types of community leaders, criminal justice, faith community, educators as well. So I wanted to start out just kind of sharing about kind of the process for this. What we have done this go around is very similar to what we've done in past assessments, and builds on that work that we've done and a lot of trending to that information. But we have made some new changes as well. We've increased emphasis on social determinants consciously as part of the survey process. And something I'll preview before we leave today is a new element was measuring adverse childhood experiences in the community. So the incidence of these ACEs questions, which are part of us as a trauma-informed community. So what I'm going to share today is really just a fraction of all of the information that we've collected. We have a report that's on the web, probably 250 plus pages of data around various health issues. So I'm really condensing that today. I'm going to focus on some of those things that we identified as the top needs for the community, but just know that there are other findings and other positive findings as well. I wanted to share one slide from the stakeholders that we talked to. So part of this process was a separate survey with providers and community leaders and social service representatives. And part of that was to ask them what they see as the top needs for the community. And I wanted to share with you the top 10 from their list. So in doing so, we asked a question around 20 health issues, asking them to identify each of them as a major problem, moderate problem, minor problem, or not a problem in our community. So from their perspective, certainly reflective in the populations whom they work with, clearly they identified mental health as their biggest concern. Almost 80% said this is a major problem in the metro area. Kind of rounding out the next 4, substance abuse, diabetes, STDs, and then a collection of issues around nutrition, physical activity, and weight. So this is, in their perspective, what they see as the top needs. So what I want to do is share with you some of the data that we collected, and we can see how well those line up. So in looking at that population survey and the secondary data that we looked at, there were essentially 11 health issues that emerged as what we call areas of opportunity. And these are issues where we saw negative trends or unfavorable comparisons to benchmark data, or where we see an impact on a great number of individuals in the community. And they fall roughly under these 4 categories of health status, modifiable behaviors, social environment influences, and services. So around some of the health status measures. Speaking to part of what Doris talked about earlier, heart disease is the leading cause of death in the metro area. Looking at 2016 death certificate information, accounting for 22% of all deaths. Cancer, nearly as many, about 18% of deaths. Lung disease, which includes things like emphysema and chronic bronchitis, is the 3rd leading cause, and on down from there. So looking at some of these chronic conditions through both our survey work and the secondary data pieces, when we look at heart disease and stroke, cardiovascular diseases, mortality rates compare generally favorable to what we see at the state and the national levels. The prevalence, the current percentage of the population with heart disease and stroke issues is a little bit lower than what we see nationwide as well. For cancer, overall, looking across all cancers, mortality rates are generally a little bit better than what we see across the state in the US. But if we look at certain cancer sites, consistently for lung cancer, we do see relatively high mortality, relatively high incidence of new cases. In our survey of households, we asked about gender and age-specific cancer screenings, and screening levels compared to other data are generally pretty good for breast cancer, cervical, and colorectal cancers. In terms of respiratory disease, that is fantastic, thank you. We measured prevalence of COPD, chronic obstructive pulmonary disease, in the population. Our current prevalence is about 9%, and it's something that has increased over some of the previous findings from our earlier assessments. In this case, we saw particularly high incidence in Pottawatomie County. Now, in terms of asthma, overall, our prevalence, also about 9%, is close to state and national data, but where we saw the largest disparity was particularly in the northeast quadrant of the city of Omaha, which, for our purposes of just breaking this out, is east of 72nd Street and north of Dodge Street. So it's a pretty large quadrant, obviously, but much higher prevalence of asthma in that part of the city. In terms of diabetes, we see a current prevalence about 11% in adults who've had a diagnosis of diabetes. That is also one where we see a much higher prevalence in the northeastern part of Omaha. In terms of mental health, there were a number of questions in our survey asking about mental health. We found that about 1 out of 4 adults is reported to have symptoms of chronic depression, which means they report having 2 or more years in their life when they felt sad or depressed on some days. That is below what we see nationally, unfortunately, but also not equally dispersed throughout our communities. In Hispanic and populations below the poverty threshold, we see that approaching 50% with those kind of periods of prolonged depression. Suicide mortality, you can see, is better than we see statewide and nationally, but over the course of the last 10 years, we have seen this creep upwards in terms of age-adjusted mortality. In terms of behaviors, identified needs around nutrition, physical activity, and weight, STDs, as well as substance use. In terms of overweight and obesity, as part of our survey, we asked respondents to give us their height and their weight, and then from that we calculated a body mass index to identify a person's weight status. Throughout the metro area, we found that 70% had a BMI of 25 or higher, meaning that they are considered to be overweight or obese. That is something that has increased in the metro area since 2011. Now in Douglas County, we have data going all the way back to 2002, and we've seen in Douglas County specifically, that percentage has increased from about 59 to about 68% over that 16-year period. On the right side, we see a percentage of adults that have a BMI of 30 or higher, meaning that they are obese, so that's included in that first chart as well. But that's kind of that higher threshold of obesity, and that also has something that has crept up slowly but consistently over the last several assessments. In terms of some of the other measures that we looked at relative to physical activity and nutrition, for example, we've actually seen fewer adults reporting that they get adequate consumption of fruits and vegetables. We have seen a lower percentage of adults also engaging in physical activity outside of their work duties. Also, since we first started measuring, we have seen a decline in use of local trails and parks and recreation facilities. So in terms of some of these modifiable behaviors around nutrition and physical activity, we're actually seeing some declines. As was referenced a couple times this morning already, we have, particularly in Douglas County, very high incidence rates associated with STDs such as chlamydia and gonorrhea. Now these charts are specific to Douglas County rather than the broader metro area, because it really is within Douglas County where we see these very high rates. And even in looking some of the data as recently as 2017, we have seen kind of an increase in gonorrhea cases, kind of even some leveling off of chlamydia, I guess, but overall still increasing in these data. Looking at some of the other data that we collected around this, when we asked people about behaviors around sexual health, and we found that more so than we found in the past, we're seeing a higher percentage of adults reporting multiple sexual partners in a given year. At the same time, we're seeing condom use that, although it's gotten a little bit better, is still well below what we see nationally. In terms of alcohol behaviors, we had a series of questions asking about behaviors over the course of the last 30 days. And using that, we've determined that 26% of adults in the metro area were determined to be excessive drinkers, meaning they've had episodes of binge drinking, or they average a high number of drinks per day over the last month. That is higher on the right side, you can see, compared to what we see in the same set of data nationally. In terms of demographic breakouts, those that I've highlighted here are statistically significant outliers. So men, younger adults, those in higher income levels, as well as non-Hispanic white and Hispanic respondents more often report these kind of high-risk alcohol behaviors. A new question to the survey this go around, I believe, was one that asked about opioid use. Now, we didn't distinguish between prescribed or not prescribed, but we found that over the course of the last year, 18% of adults report that they have used an opiate or opioid drug. Across the metro area, we saw particularly high prevalence in the western Douglas County zip codes, kind of Elkhorn on east or on west, as well as across the river in Pottawatomie County. That's where we saw the highest percentages. A couple indicators around injury and violence in terms of mortality rates for some of the leading causes of accidental deaths in the community. We compare somewhat favorably for things like firearm-related deaths, motor vehicle accidents, although parts of the metro area do not fare as well for those. Potawatomi, a higher rate of motor vehicle crash deaths. Douglas and Potawatomi, higher for gun-related deaths. In terms of falls, specifically among those age 65 plus, we do see a relatively high rate of mortality associated with that throughout the metro area, especially in Potawatomi County. In terms of violence, when we look at violent crime rates across the community, these are relatively high both here in Douglas as well as across the river in Potawatomi compared to state and national rates. The final category looks at kind of the clinical delivery of health care. And as part of this survey, as in years past, we have asked about not only insurance coverage, but also various other types of barriers to accessing health care. So this represents 7 questions in our survey. And for example, on the left, we found that 11.9% of adults said that there was a time in the past year when they needed to see a doctor, but they couldn't because they couldn't get there during office hours. 11.8% didn't get a medical appointment when they needed it, so they forego that appointment. 10.5% didn't get a needed prescription in the past year because of the associated cost. 9.4% didn't have a medical appointment because of the cost, whether it be no insurance, the copay, co-insurance, etc. And on down from there, you can see it drops off then a little bit less impact for finding doctors, transportation, and then language and culture as barriers. And we did do this survey in both English and Spanish, just so you know. In looking across the trend data, we have seen some improvement, lesser impact of cost on people accessing doctors and prescriptions over the past year, but those still, as in years past, are much more prevalent in the northeastern part of the city. Transportation is also something that we see more of an issue both in northeast and southeast parts of Omaha. Compared to national data, we actually fare pretty well. For most of these, all but that first one, you can see that the impact of these on the population, these barriers of access, are significantly better than what we see in a similar survey of adults across the U.S. Now, if we take those 7 questions and roll those up into one number, it's about 30% of adults, so not quite 1/3, who've encountered one or more of these barriers of accessing healthcare. So it's a significant share of our population. Looking across demographics, most impacted certainly are those who are low income. Very low income group is below poverty, low income up to 200% of poverty. Young adults, women, as well as African American, and folks in this other race category, which includes things like Asian, Native American, etc. The last thing I want to leave you with is kind of apart from the specific needs we identified, but it is one of the new question series around the social determinants, which of course are a context for all of these questions that we've talked about. And it's around what's called adverse childhood experiences. So as part of our survey, we asked the adults that we surveyed that when they were children, if they had experienced various types of trauma or adverse experiences. And what we found was that most prevalent in our adult population is 37% of adults who reported experiencing repeated emotional abuse, what they perceive as emotional abuse when they were children. Household substance abuse was an issue for 26% when they were growing up. 24% were children of divorce or parental separation. About 18% said that they were victims of physical abuse beyond, just spanking, but more physical abuse. Or also mentioned that they lived with someone who had serious mental illness when they were children. 16% said they lived with an adult who was a victim of domestic violence. 12% were themselves sexually abused by our reporting. And 6% lived with a family member who at some point was incarcerated. So the research has shown that these experiences of trauma and dysfunction in our youth do impact how we, our health and our behaviors in later years. So if we look at multiple factors, we kind of grouped folks into whether they've had none of these ACE scores, or a low number, which is 0 to 3, or a high number of ACE risk factors, which is 4 or more. And that's really 15% of our population that has experienced 4 or more of these factors when they were growing up. In Northeast Omaha, it was about 19%. Sarpy County also was a little bit high at 18.5%. And the last thing I want to share is how these kind of correlate to some of the other things that we measured in our survey. So if we break our survey into the group of respondents who have high ACE scores and those who have no or low ACE scores, the gray shaded area represents kind of the various questions for those with low or no ACEs. The red area, those with high ACE scores. So that red area represents kind of the gap in health that we see across various factors between those with or without these incidences of trauma. So really things with significant gaps are things like depression, access to health care, people who themselves are the victims of intimate partner violence, stress, mortgage stress, various things related to economics, and down from there. So I think there's some exciting possibilities around this as we continue to look at these data and understand some of the health issues as we start to develop implementation strategies.